Okay, let's unpack this. We are diving deep today into a stack of material all about the pathology of the female genital tract and the complexities of pregnancy and placental disorders. We've got excerpts here from a pathology textbook covering everything from the foundational building blocks to infections, specific organ issues, and the unique challenges that can arise during gestation.
Right.
Our mission with this deep dive is to really understand this material, not just memorize terms, but grasp the fundamental processes, the why behind how these diseases happen.
Exactly.
Giving you that shortcut to being well-informed, like experts in the field understand the concepts.
That's right. This area is a fascinating interplay of development, hormones, and outside influences like infections.
Right.
To truly get it, you need to see how these systems are built, how they respond to stress, and how diseases unfold across different parts of the reproductive system.
Okay.
We'll pull out the essential insights from your sources and connect the dots, highlighting the most impactful information.
Fantastic. So we're going to start right at the beginning, looking at how these organs develop.
Good place to start.
Then we'll explore common entry points like infections and how they can spread. From there, we'll take a guided tour, organ by organ of vulva, vagina, cervix, uterus, fallopian tubes, and ovaries,
Remembering all the bases.
examining the unique issues each faces. And we'll wrap up by exploring the pathology specific to pregnancy and the placenta.
It's a lot, but essential.
It's a comprehensive journey, but we're going to go deep and make sure you walk away with a solid understanding of the underlying pathology.
Okay.
To truly appreciate the pathology, we need to start with the foundation, how the female genital tract is built during development. Your sources take us back to the very early stages, just a few weeks into gestation.
It all begins with primordial germ cells.
Okay?
Right, these cells start in the yolk sac and make their way to the urogenital ridge. Around week 5 or 6, this migration triggers the formation of the ovary's outer layers and supportive tissue.
And parallel to that, you have the Müllerian, or perimesonephric, ducts forming. They grow downwards and eventually fuse together in the midline.
That fusion is key.
Think of the upper parts as two separate tubes, and the lower parts as fusing into one structure.
So the two unfused upper parts become the fallopian tubes.
Right.
And that lower fused part, that's the blueprint for the uterus, the cervix, and the upper portion of the vagina.
Exactly. Tubes on top from the unfused Müllerian ducts,
Yep.
and the uterus, cervix, and upper vagina from the fused lower section.
Precisely.
Okay, so where does the rest of the vagina, the lower part, and the external bits come from?
That's where the urogenital sinus comes in. It develops from the cloaca, which divides.
Oh, okay.
The urogenital sinus forms the lower vagina and the vestibule, that external entry area.
Got it. Müllerian ducts for the internal upper structures, and the urogenital sinus for the lower vagina and vestibule.
You got it.
What about the Wolffian or mesonephric ducts? I saw them mentioned.
Ah, yes. In females, these typically disappear. But sometimes remnants hang around into adulthood.
Leftovers.
Exactly. You can find little bits of epithelial tissue near the ovaries, tubes, or uterus. And importantly, in the cervix and vagina, these remnants can form fluid-filled sacs called Gartner duct cysts.
Gartner duct cysts.
It's interesting how a developmental leftover can manifest later as pathology.
So these cysts are essentially vestiges of a structure that wasn't supposed to stick around.
Precisely. And understanding this embryology gives us a crucial insight from your sources. The epithelial lining of the entire female genital tract, plus the surface of the ovary, share a common origin.
A common origin.
From the same embryonic tissue, coalomic epithelium.
That common origin is really a key nugget. It helps explain why you see similar types of benign and malignant tumors popping up in different locations throughout this system, and even nearby on the peritoneum. It's like they all come from the same seed tissue.
Exactly. And that shared history lays the groundwork for the kinds of diseases we see in these organs. Issues arising during pregnancy, a wide range of infections, various types of tumors, and problems caused by hormonal imbalances.
Which brings us neatly to infections, a really common entry point for pathology in the female genital tract.
Very common.
Your sources highlight a broad spectrum of organisms, from things like candida and trichomonas that might just cause discomfort to more serious players.
Absolutely. There are organisms like Neisseria, gonorrhea, and chlamydia, which can lead to serious long-term issues like infertility.
Right, devastating consequences.
Herpes streptococcus is important because it's linked to preterm deliveries. And viruses like HSV and HPV can cause significant problems.
Yeah, HSV and HPV.
From painful recurrent outbreaks with HSV to the development of cancers years later with high-risk HPV types.
The source emphasizes how many of these are sexually transmitted. Trichomonas, gonorrhea, chlamydia, HSV, HPV, syphilis, and others.
Yes, transmission is key.
Recognizing these transmission routes is fundamental to understanding prevention and how these infections spread.
Let's take a closer look at some of the lower genital tract infections, starting with herpes simplex virus, HSV.
Okay, HSV.
Your sources distinguish HSV1, commonly associated with cold sores, and HSV2, typically linked to genital herpes. Though sexual practices mean you can find either type in either location now.
Yeah, the lines are blurred there.
It's quite prevalent. By age 40, about 30% of women have antibodies to HSV2, meaning they've been exposed.
Wow, 30%. And about a third of those exposed will experience symptoms.
That's right. When symptoms do appear, it's usually 3 to 7 days after transmission.
Okay.
It starts with red spots that turn into fluid-filled blisters, which then break down into painful ulcers. You can also have flu-like symptoms initially.
Malaise, fever.
Exactly. And locally, there might be discharge, pelvic pain, or pain with urination if the urethra is affected.
Those lesions are packed with viral particles, which is why transmission is high during an active outbreak.
Highly infectious.
And here's where it gets really interesting. The virus doesn't just stay local or get eliminated.
No, it's quite clever. The virus travels up the nerves from the infected area and settles in the nerve clusters near the base of the spine, the lumbosacral nerve ganglia.
Hides out in the nerves.
It sets up a latent infection there, which can persist indefinitely.
And certain triggers, stress, physical trauma, other infections, even hormonal changes can reactivate the virus, causing new outbreaks of lesions.
That's the recurrence mechanism. Recurrences are also more frequent and severe in people with weakened immune systems.
So even when there's no visible outbreak, the virus is still hiding, ready to potentially reactivate. What about diagnosing it?
Looking at cells under the microscope can show characteristic changes. The source points out you can see features like multiple nuclei within a single cell.
Multinucleated cells.
And specific viral inclusions inside the nucleus, often described as having a ground glass appearance. These are microscopic clues to the infection.
Right, those cytopathic changes. Transmission usually happens during active outbreaks, but your sources note that even without visible lesions, the virus can be shed.
Subclinical shedding, yes?
From the skin or mucosal surfaces.
Mm-hmm.
This is a key aspect of transmission dynamics.
Absolutely. It's also noted that HSV is more easily transmitted to women than to men, and prior HSV1 exposure might offer some partial protection against HSV2 infection.
Interesting. The most serious concern mentioned is transmission to a newborn during vaginal delivery.
Neonatal herpes.
If the mother has an active primary infection, as this carries a very high risk for the baby. That's why cesarean delivery is often recommended in those situations.
Crucial intervention. The source also points out that having active genital HSV infection increases the risk of both acquiring and transmitting HIV-1.
Ah, that connection is important too. Diagnosis involves looking at the clinical presentation and using tests to detect the virus itself.
Clinical picture plus lab tests. Tissue culture, or rapid tests like PCR, are sensitive ways to find the virus in fluid from the lesions.
And blood tests.
Blood tests for antibodies tell you about past exposure or latent infection, but they don't necessarily indicate an acute primary infection.
Got it. And treatment. The sources mention antivirals like acyclovir can help shorten the length and severity of symptomatic outbreaks.
They manage symptoms, yes.
But they don't eliminate the latent virus. The goal of a vaccine to prevent initial infection is tantalizing, but hasn't been fully realized yet.
Still an ongoing quest. Prevention methods like condoms and antiviral medication during outbreaks help reduce but don't completely eliminate the risk of transmission.
Okay, moving on to some other common lower genital tract infections.
Yeah.
Molluscum contagiosum,
Caused by a pox virus.
and is often sexually transmitted in adults. It causes distinctive raised, pearly bumps with a little dent in the center.
That umbilicated papule. Under the microscope, the source points out characteristic inclusions inside the cells.
Then, the incredibly common fungal infections, usually candida. Yeast is a normal part of the flora, but it can overgrow when the balance is disrupted.
Right, opportunistic. Things like poorly controlled diabetes, antibiotic use, pregnancy, or a weakened immune system can create conditions for an infection.
Symptoms are typically intense itching, redness, swelling, and a thick, curd-like discharge.
Classic candidiasis symptoms. In severe cases, you can even get ulcerations.
Diagnosis is often done by simply looking at a sample under the microscope, KOH mount, or sometimes seen on a pap smear.
Usually straightforward. While sexual transmission is possible, it's generally seen as a disruption of normal flora rather than a strictly STI.
Contrast that with Trichomonas vaginalis.
A protozoan.
This is a protozoan and is almost exclusively transmitted sexually. It can cause a bubbly yellow or greenish discharge, discomfort, and painful urination or sex.
And on exam, a classic finding is the strawberry cervix due to tiny areas of bleeding, punctate hemorrhages.
Another common one is Gardnerella vaginalis, the primary cause of bacterial vaginosis.
Yes.
This isn't strictly an STI either, but sexual activity can be a factor. The source describes a thin, green-gray discharge with a characteristic fishy odor.
That amine odor is distinctive. Pap smears can show clue cells, which are vaginal cells coated in bacteria.
Clue cells.
It's a polymicrobial infection, meaning multiple types of bacteria are involved. Your sources also note that in pregnant patients, bacterial vaginosis has been linked to an increased risk of premature labor.
That's a significant complication. Ureaplasma urolithicum and Mycoplasma hominis are also mentioned
More bacteria?
as bacteria that can cause inflammation of the vagina and cervix, and have also been implicated in serious pregnancy complications like infection of the membranes, chorioamnionitis, and premature delivery.
Yes, linked to adverse pregnancy outcomes.
And finally, chlamydia trachomatis. It often starts as cervicitis, but as your sources point out, it's notorious for ascending upwards,
It's a silent sputter.
leading to inflammation of the uterine lining, endometritis, and fallopian tubes, salpingitis, which are key components of pelvic inflammatory disease.
Which brings us to pelvic inflammatory disease, or PID.
Right, PID.
This is a critical concept because it's when those lower tract infections spread upwards to involve the uterus, fallopian tubes, ovaries, and surrounding structures.
The classic symptoms are pelvic pain, tenderness around the ovaries and tubes, fever, and vaginal discharge.
Absolutely. Neisseria gonorrhea is a major cause, and PID is considered the most serious complication of gonorrhea in women.
Gonorrhea's biggest risk.
Chlamydia is also a very common culprit. It's also important to remember puerperal infections, those that occur after an abortion or delivery.
Postpartum or post-abortion infections.
These are often polymicrobial, involving bacteria like staph, strep, and E. coli, and they can also cause PID.
The sources describe different ways the infection can spread. Gonococcal PID tends to spread along the mucosal surface,
Like climbing up the lining.
starting in the cervix and moving up into the tubes.
Non-gonococcal or puerperal PID, on the other hand, is thought to spread more through the lymphatic and venous systems within the tissues.
Through the walls, basically.
Yes. This means it tends to involve the deeper layers of the organ walls more, not just the surface lining.
Looking at the fallopian tubes under the microscope in acute PID, the source describes them as swollen, inflamed, filled with inflammatory cells, and sometimes containing pus.
Acute salpingitis.
In chronic PID, after the initial infection, you see scarring. The normal folds inside the tube fuse together, creating blocked gland-like spaces.
That scarring is the critical long-term consequence because it directly impacts fertility and significantly increases the risk of ectopic pregnancy,
Right, the blockage.
where a fertilized egg implants outside the uterus, usually in the scarred tube.
And the source notes that non-gonococcal PID is more likely to spread beyond the tubes,
Because the surrounding structures.
to involve the broad ligaments, other pelvic organs, and the lining of the abdomen peritoneum. Bacteremia, where bacteria enter the bloodstream, is also more frequent with strep or staph PID.
Systemic spread is a bigger risk there.
Complications can be immediate, like peritonitis or bacteremia spreading to cause endocarditis or meningitis.
Acute, serious stuff.
But the chronic effects are profound. Infertility due to blocked tubes, a much higher risk of ectopic pregnancy, persistent pelvic pain, and even intestinal obstruction caused by adhesions forming between the bowel and the inflamed pelvic organs.
Long-term morbidity is significant. Treatment involves antibiotics. Gonococcal infections are generally responsive, although antibiotic resistance is an ongoing concern.
Always a worry.
Walled-off collections of pus, like tubo-ovarian abscesses, can be harder to treat and sometimes require surgery.
Drainage.
Post-abortion or postpartum PID is particularly challenging due to the wide variety of bacteria that can be involved.
Okay, let's shift our focus and go organ by organ, starting with the vulva, the external genitalia.
Right, the vulva.
Your sources note that while it's a small part of gynecologic practice, it shares many conditions common to skin elsewhere on the body. Because it's exposed, it's also prone to superficial infections.
Makes sense. Nonspecific inflammation can occur, especially in people with weakened immune systems. And like skin anywhere, various cysts and tumors can develop.
It's the interface with the outside world. One condition that's relatively specific to this area is the Bartholin cyst.
Ah, yes, the Bartholin gland.
This happens when the duct of the Bartholin gland, which provides lubrication, gets blocked, often due to inflammation. They can become quite large and cause pain or discomfort.
Quite common. The source describes them as being lined by transitional or squamous epithelium. Treatment typically involves draining the cyst or a procedure called marsupialization to keep it open.
The sources also discuss non-neoplastic epithelial disorders of the vulva, which often present clinically as leukoplakia,
Those white patches.
those white thickened areas. Leukoplakia is just a description white patch. It can be caused by various things, including inflammation or precancerous changes, but the source focuses on two key non-neoplastic causes, lichen sclerosis and squamous cell hyperplasia.
Two important distinctions. Lichen sclerosis is described as thin, smooth, white plaques or macules that can spread and join together. Over time, it can cause the tissue to thin and shrink, potentially causing the labia to fuse together and the vaginal opening to narrow. Atrophy and scarring.
And under the microscope.
The source details characteristic changes. A thin outer layer of skin, degeneration in the lowest layer, thickening of the very top layer, hyperkeratosis, a band of inflammatory cells below, and thickening and scarring of the underlying tissue, dermal sclerosis.
It's most common after menopause, but can occur anywhere on the skin. While the exact cause is uncertain, there's a suggestion of autoimmune involvement.
Possibly autoimmune. Importantly, your source states that lichen sclerosis itself is not premalignant in most cases, but there's a slightly increased risk of developing squamous cell carcinoma in affected women.
Slightly increased risk, not directly premalignant. Contrast that with squamous cell hyperplasia, sometimes called hyperplastic dystrophy.
Right, the other white patch cause. The source presents this as a non-specific reaction, often to chronic irritation like rubbing or scratching due to itching. It also appears as leukoplakia clinically.
So reactive thickening.
Pretty much. Microscopically, you see a marked thickening of the epidermis, acanthosis, and hyperkeratosis. There might be some inflammation underneath. The key distinction from precancer is that although the cells are dividing more rapidly, they lack cellular atypia. Their nuclei and appearance are normal for squamous cells.
No atypia is the key.
Exactly. The source states it's not considered premalignant, but can sometimes be found alongside vulvar cancers.
Moving to some benign growths that stick out from the surface, the source highlights condyloma acuminatum, the common genital wart.
HPV related.
These are caused by HPV infection and appear as bumpy papillary lesions.
The microscopic giveaway for HPV infection, including in these warts, is wild coilocytic atypia.
Ah, the coilocytes.
Your sources describe this as atypical enlarged nuclei that look darker and more irregular, often surrounded by a clear space or halo. This is the cytopathic effect of the virus on the squamous cells.
Okay, now let's talk about the more serious squamous neoplastic lesions, VIN, or vulvar intraepithelial neoplasia,
The precursor lesions.
which are precursor lesions and invasive vulvar carcinoma. Vulvar cancer isn't very common, only about 3% of gynecologic cancers, and usually affects women over 60. SCC is the most frequent type.
Right. And your sources divide these into two distinct pathways based on their cause. This distinction is really important for understanding the disease.
Two pathways.
About 30% of vulvar SCCs are the bacilloid and warty types. These are strongly linked to high-risk HPV, most commonly HPV 16. They tend to affect younger women compared to the other type, averaging around 60.
HPV-related younger women.
These arise from classic VIN, which is considered the equivalent of carcinoma in situ in other squamous locations. Risk factors for classic VIN are the same ones linked to HPV exposure, younger age of first sexual activity, multiple partners, or a partner with multiple partners.
Standard HPV risk factors.
Classic VIN lesions are often found in more than one spot on the vulva, and a significant number of these women, 10-30%, also have HPV-related lesions in the vagina or cervix.
Multicentric disease.
The source notes that classic VIN can sometimes regress, particularly in younger women. But the risk of progression to invasive cancer is higher if you're over 45 or have a weakened immune system.
So age and immune status matter for progression.
Microscopically, classic VIN shows thickening of the epidermis with atypical cells throughout, increased cell division, and a loss of normal maturation towards the surface. Invasive basaloid carcinoma has nests of small, immature cells, while invasive warty carcinoma is bumpy and shows those HPV-related coilocytic changes.
Got it. The other major group is keratinizing squamous cell carcinomas,
The more common type, 70%.
which make up about 70% of vulvar SECs. Your source emphasizes these are not related to HPV. They are more common in older women, typically around 75.
Unrelated to HPV, older women, these cancers develop from differentiated VIN.
Differentiated VIN, how does that look?
Microscopically, differentiated VIN has atypia only in the lowest basal layer, but the cells above it still mature normally, and you often see thickening of the outer keratin layer.
Basal atypia only.
When invasive, these cancers show nests and cords of malignant squamous cells invading the underlying tissue, often forming prominent keratin pearls, which are swirls of keratin.
Keratin pearls, typical of SEC.
The source notes that the risk of classic VIN progressing to invasive cancer depends on factors like how long it's been there, how widespread it is, and the patient's immune status.
Makes sense.
The HPV-unrelated invasive cancers, often associated with long-standing conditions like lichen sclerosis, squamous hyperplasia, or differentiated VIN, can be sneaky. They might look like harmless skin conditions initially, leading to delayed diagnosis.
Insidious onset.
Once invasive cancer is present, the risk of spread depends on the tumor size, how deep it goes, and whether it's invaded blood or lymphatic vessels.
Standard cancer staging factors.
The initial spread is typically to the lymph nodes in the groin, then to pelvic and further nodes. Eventually, it can spread through the bloodstream to organs like the lungs or liver.
Prognosis is strongly tied to stage. Small lesions under 2 cm have a good 5-year survival after surgery, around 90%, but larger tumors or involvement of lymph nodes significantly worsen the outlook.
Stage is critical for vulvar cancer.
Beyond squamous lesions, the vulva also has glandular structures, including apocrine sweat glands, which can develop tumors. These are less common but important to recognize.
Right, the glandular neoplasms. Papillary hydradenomas is one example. It arises from these sweat glands and presents as a small bump, often on the labia majora. Sometimes it can break open and ulcerate, which can raise concern for cancer clinically.
Mimicking cancer.
Microscopically, it looks remarkably similar to a benign lesion found in the breast called an intraductal papilloma. It has papillary structures lined by 2 cell layers, including myoepithelial cells, which are characteristic of sweat glands, and breast tissue.
Like a breast papilloma, interesting. Another rare but distinctive lesion is extramammary Paget disease of the vulva.
Yes, Paget disease. Your sources describe it as a persistently itchy, red, scaly, crusting patch with irregular map-like borders.
Sounds like eczema, maybe.
It can look like it. Under the microscope, you see large, pale staining cells, called Paget cells, spreading within the outer layer of the epidermis. These cells sometimes contain mucin.
Paget cells in the epidermis.
It's crucial to note a key difference compared to Paget disease of the nipple associated with breast cancer. Vulvar Paget disease is typically confined to the epidermis and not associated with an underlying invasive cancer in the vast majority of cases.
That's a really important distinction from breast Pagets.
Absolutely. However, because the cells can spread widely within the epidermis, wide surgical removal is necessary. Prognosis is poor only if these intraepidermal Paget cells develop into an invasive cancer, which is rare.
Moving inwards now to the vagina. Your sources describe it as being quite resilient and relatively resistant to diseases spreading from the vulva or cervix.
Pretty tough tissue. Primary lesions arising within the vagina itself are relatively uncommon.
That resilience is definitely a key feature. However, developmental anomalies can occur, like having a septum dividing the vagina or a double vagina. Mullerian fusion defects.
Which happens when the Mullerian ducts don't fuse completely. These are often associated with a double uterus. Other anomalies can be related to genetic conditions or past exposure to the drug DES in utero.
DES exposure is a classic cause of some vaginal anomalies, though rarer now.
Cysts can also pop up. We mentioned Gartner duct cysts earlier. Those are from Wolffian duct remnants and are typically found on the sidewalls.
Right, those Wolffian vestiges again. You can also get mucus cysts in the upper vagina from Mullerian epithelium. And endometrial tissue can sometimes implant in the vagina, causing endometriosis, which can look like a mass and mimic a tumor.
Endometriosis in the vagina, okay. Benign tumors of the vagina are rare. Mostly things like stromal polyps, leiomyomas, fibroids, or hemangiomas, blood vessel tumors, in reproductive age women.
Fairly uncommon. For malignant tumors, the most common type isn't actually a primary vaginal cancer, but rather cancer that has spread to the vagina, most often from the cervix.
Metastasis from the cervix is most common. Primary squamous cell carcinoma of vagina is quite rare, making up only about 1% of female genital tract cancers. And like cervical and vulvar SEC, it's strongly associated with high-risk HPV. HPV-driven again. Your sources highlight that the single greatest risk factor for developing primary vaginal SCC is a previous history of cervical or vulvar carcinoma.
Ah, that's key. Prior cancer history.
About 1–2% of women who've had invasive cervical cancer will later develop vaginal SCC. It arises from vaginal intraepithelial neoplasia, or vein, which is the precursor lesion, analogous to VIN and cervical SCL.
Vein, the vaginal precursor.
Most invasive vaginal cancers are found in the upper part of the vagina, especially the back wall near the cervix. Metastasis patterns differ. Cancers in the lower two-thirds spread to lymph nodes in the groin, while those in the upper vagina spread to the regional iliac nodes deeper in the pelvis.
Location dictates spread. Your sources also mention a very rare, specific type of cancer that occurs in infants and children under the age of 5, embryonal rhabdomyosarcoma.
Sarcoma botryoides, sometimes called sarcoma botryoides. These are malignant tumors derived from primitive muscle cells called embryonal rhabdomyoblasts.
From immature muscle. Grossly, they have a very distinctive appearance. Soft, bulky masses that look like clusters of grapes hanging out of the vagina.
Grape-like clusters. Memorable.
Microscopically, you see small abnormal cells with oval nuclei and sometimes cells that look like tiny tennis rackets. In very rare cases, you can even see immature muscle striations. A characteristic feature is a layer of crowded cells just under the surface epithelium, called the cambium layer.
Cambium layer right under the surface.
The source notes that these can be mistaken for benign inflammatory polyps due to their appearance. They tend to be locally invasive and can be life-threatening by growing into surrounding tissues, penetrating into the abdominal cavity, or blocking the urinary tract.
Aggressive locally.
Treatment involves a combination of surgery and chemotherapy, and outcomes are much better with early diagnosis. Now, let's focus on the cervix, that narrow lower part of the uterus. This is a critical area in gynecologic pathology, largely due to the transformation zone.
The T-zone, yeah.
This is the area where the glandular epithelium lining the inside of the cervix meets the squamous epithelium covering the outside.
The squamocolumnar junction, specifically where it moves over time. And in this zone, the glandular epithelium undergoes a change called squamous metaplasia.
Squamous metaplasia.
Your sources point out that the immature squamous cells in this transformation zone are particularly susceptible to HPV infection, and this is where the vast majority of precursor lesions and invasive cancers of the cervix arise.
It's the bullseye for HPV-related pathology.
Exactly.
Inflammation of the cervix, or cervicitis, is incredibly common. The sources explain the normal defense mechanisms here. The healthy vaginal microbiome, particularly lactobacillobacteria, produces lactic acid, keeping the pH low, below 4.5.
The acid environment.
Which inhibits the growth of many pathogens. However, things like menstrual bleeding, intercourse, douching, or antibiotic use can raise the pH, allowing other organisms to overgrow.
Disrupting that balance. Specific bacteria like Gonococcus, Chlamydia, and mycoplasmas, as well as viruses like HSV, can cause significant acute or chronic cervicitis.
Identifying these infections is important, not just for local symptoms, but because they can spread upwards to cause PID, lead to complications during pregnancy, and are sexually transmitted.
Right, bigger implications. Your sources also note that marked inflammation can cause abnormal-looking cells on a pap smear, making it difficult to interpret reactive changes.
Which leads us directly into the squamous neoplastic lesions of the cervix, primarily cervical carcinoma. The average age for diagnosis is around 45–50.
Midlife usually. Squamous cell carcinoma, SCC, is the most common type, making up about 80%. Adenocarcinoma is next, 15%, arising from a precursor called adenocarcinoma in situ. Rare types include adenosquamous and neuroendocrine carcinomas.
And here's the really impactful takeaway from your sources. Virtually all cervical cancers, regardless of the specific type, are caused by high-risk HPVs.
The HPV connection is undeniable.
The slow progression from the initial precursor lesion to invasive cancer, often taking decades, is why screening is so effective.
That long lead time is crucial. It gives us a long window to detect and treat lesions before they become cancerous.
Understanding the role of HPV is fundamental. Your sources distinguish high-risk HPV types, about 15, with 16 and 18 being the most common culprits for cancer, from low-risk types that cause genital warts.
High risk versus low risk types, yes. Genital HPV infection is extremely common, and most people clear the virus spontaneously without ever knowing they had it.
Most clear it.
About 50% in 8 months and 90% in 2 years, according to the sources. High-risk types tend to persist longer, and it's persistent infection with a high-risk type that significantly increases the risk of developing precursor lesions and eventually cancer.
Persistence is the problem.
The source delves into the cellular mechanics of how HPV causes cancer. It boils down to viral proteins, specifically E6 and E7.
E6 and E7.
Interfering with critical tumor suppressor proteins in our cells, P53 and RB.
The cell cycle guardians.
Think of P53 and RB as cellular policemen that stop cells with damaged DNA from dividing or tell them to self-destruct. HPV's E7 protein binds to and inactivates RB, essentially taking one of these policemen out of action, pushing the cell to divide uncontrollably.
Takes out RB.
High-risk HPV's E6 protein goes after P53, leading to its degradation, removing the other policeman. E6 also helps the cell become immortal by activating telomerase.
Takes out P53 and boosts telomerase.
This unchecked proliferation, especially when DNA repair is also impaired by E7, makes the cells much more likely to accumulate other mutations needed for cancer.
So it opens the door for more mutations.
Right. Low-risk HPV proteins have a weaker effect on RB and don't interact with P53, which is why they cause warts, but rarely cancer.
Lower impact.
Your sources also mention that in most cervical cancers, the HPC DNA integrates into the host cell's genome, which boosts the expression of E6 and E7 and can mess with nearby genes, driving the cancer process further.
Integration makes it worse.
In precursor lesions and warts, the viral DNA is usually just floating around as a circular piece, episomal. Other factors like co-infections, smoking, or a weakened immune system can act as co-carcinogens, influencing whether an HPV infection persists and progresses to cancer.
Cofactors matter too.
Your sources detail the classification of cervical precursor lesions, now primarily using a two-tiered system. Lower-grade squamous intraepithelial lesion, LSIL, which used to be called CIN1, and high-grade squamous intraepithelial lesion, HCIL, encompassing CIN2, CIN3, and carcinoma in situ.
LSIL is considered the earliest change, mild dysplasia with atypical cells limited to the lowest third of the epithelium.
Basal third involvement. Your sources describe this as representing a productive HPV infection. The virus is actively reproducing in the cells, causing those characteristic coilocytic changes, the halos, and expanding the expression of markers like Ki67 and P16 beyond the normal basal layer.
Productive infection making virus.
The good news, most LSILs regress on their own, about 60%, some persist, 30%, and only a small fraction, 10%, will progress to HSIL. Importantly, LSIL does not progress directly to invasive cancer.
Mostly regress, low progression risk. HSIL, on the other hand, represents a more significant, potentially irreversible derangement.
Higher risk lesion. Here the atypical cells extend through more than 2/3 or even the full thickness of the epithelium. This is driven by progressive deregulation of the cell cycle by HPV.
Lost control. HSIL carries a high risk of progression to invasive carcinoma, about 10% over 2 to 10 years if untreated.
Significant risk. Most HSIs develop from LSIL, but some arise de novo. The risk of progression is also influenced by the specific high-risk HPV type, with HPV16 having a higher risk.
HPV type matters.
The progression from initial infection to invasive cancer is typically a slow process, taking many years or even decades.
Decades, usually. Microscopically, diagnosing SIL is based on cellular atypia. The nuclei of the squamous cells are enlarged, darker staining, have coarse chromatin, and vary in size and shape.
Looking for those abnormal nuclei, the cytoplasmic halos, coilocytic change, are often present, particularly in LSIL. The distinction between LSIL and HSIL is primarily based on how far up the epithelium the immature atypical cells extend.
How much of the thickness is involved?
Staining for markers like Ki67, proliferation marker, and P16, marker overexpressed due to high-risk HPV activity, helps confirm the diagnosis and grade.
P16 is a key marker for high-risk HPV effect.
Yes, very useful. For invasive cervical carcinoma, again, the average age is 45-50, and it's overwhelmingly caused by high-risk HPVs. The most common type is SCC, 80%, followed by adenocarcinoma, 15%.
Invasive SCC and adeno.
Invasive SCCs appear as nests and cords of malignant squamous cells pushing into the underlying connective tissue. They can be keratinizing, forming those visible keratin pearls, or non-keratinizing,
invading the stroma.
Adenocarcinomas are made of malignant glandular cells resembling the endocervix. forming abnormal glands with dark, atypical nuclei. Adenocarcinoma in situ is the non-invasive precursor, showing severely atypical glandular cells confined to the glands.
AIS, the adeno precursor. Clinically, the average age is 45-50. The stage at diagnosis is the single most important factor for prognosis.
Stage is paramount. If caught very early, superficially invasive, the 5-year survival is 100%. But if it has spread beyond the pelvis, survival drops dramatically to less than 20%.
Huge difference based on stage.
Your sources note that death from advanced cervical cancer is usually due to the local effects of the tumor invading nearby structures, particularly blocking the ureters leading from the kidneys, causing kidney failure rather than distant metastases.
Local invasion causing kidney failure is often the cause of death.
This is why screening and prevention are such a triumph in cervical cancer. The source details the Pap smear recommendations, which start around age 21 and involve collecting cells from the cervix to look for those precancerous changes, SIL.
The Pap smear success story.
The frequency depends on age and HPV testing results. If an abnormal Pap smear is found, the next step is typically colposcopy, where the cervix is examined with a magnifying scope after applying acetic acid, which makes abnormal high-density areas turn white, aceto-white. This guides biopsies.
Aceto-white changes guide the biopsy.
LSIL might be simply monitored as many regrafts or sometimes treated with local ablation. HSIL requires treatment, usually involving removing the abnormal area with procedures like cervical conization.
Treat HSL, often monitor LSIL.
And the really exciting advance is the HPV vaccination. Your sources recommend it for young adolescents, boys and girls, typically at ages 11-12, and can be given up to age 26.
HPV vaccine, a major prevention tool.
Current vaccines protect against the most common high-risk types, like 16 and 18, which cause about 70% of cervical cancers, as well as some low-risk types that cause genital warts.
Covers the main cancer culprits and wart types.
Vaccinating boys is important because it reduces transmission and also protects them from HPV-related anal and oropharyngeal cancers.
Protects boys and reduces spread.
The sources mention protection lasting up to 10 years or more. Even with vaccination, screening is still necessary because the vaccines don't cover all high-risk HPV types.
Still need screening. Your sources also briefly mention the endocervical polyp.
Common benign growth.
A common benign growth made of fibrous tissue covered by the glandular endocervical epithelium.
Okay, moving on to the endometrium, the inner lining of the uterus.
The endometrium.
This is a complex organ, constantly changing throughout the menstrual cycle and highly responsive to hormones, particularly estrogen and progesterone.
Hormone central. One significant disorder here is endometriosis. This is defined as the presence of endometrial glands and stromal tissue outside the uterus in ectopic locations.
Endometrial tissue gone astray. Your sources list common sites like the ovaries, fallopian tubes, and surfaces within the abdominal cavity, but it can sometimes occur in more distant locations.
How does it get there?
There are several theories about how it gets there. One is regurgitation of menstrual tissue backwards through the fallopian tubes. Another is metaplasia, where other tissue types transform into endometrial-like tissue. Metastasis through lymphatics or blood is also proposed, as is the idea of stem cells playing a role.
Multiple theories.
Regardless of how it gets there, this misplaced tissue behaves like normal endometrium. It responds to hormones and bleeds cyclically. This bleeding at ectopic sites leads to inflammation, scarring, nodules, and adhesions.
Cyclic bleeding and inflammation outside the uterus.
The ovaries are very commonly involved and can become distorted by cysts filled with old blood, often called chocolate cysts or endometriomas.
Chocolate cysts on the ovary.
Deep infiltrating endometriosis can grow aggressively into tissues and cause significant fibrosis. Clinically, it's a significant cause of pain and infertility in reproductive age women, affecting about 10% of this population.
1 in 10 women. Significant pain and infertility.
Symptoms include painful periods, dysmenorrhea, painful intercourse, dyspareunia, chronic pelvic pain, and irregular menstrual bleeding. Infertility affects 30–40% of women with endometriosis.
Your sources discuss the complex relationship between endometriosis and cancer.
Yes, the endo-cancer link. While the vast majority of endometriosis does not become cancerous, there is an association, particularly with certain types of ovarian cancer. Malignant transformation of superficial or ovarian endometriosis is uncommon and extremely rare in deep infiltrating endometriosis.
Mostly benign, but a link exists.
Interestingly, mutations commonly found in cancer genes like KRAS and PIK3CA have been detected in the epithelial cells within deep infiltrating endometriosis, though the clinical significance of this is still being being explored.
Mutations found even in the benign-appearing tissue.
A stronger link exists with ovarian cancer, specifically the endometrioid and clear cell types. Women with endometriosis have about a threefold increased risk of developing these types of ovarian cancer.
Threefold risk for endometrioid and clear cell ovarian cancer.
Shared genetic mutations between endometriosis and these ovarian cancer types support the idea that endometriosis can act as a precursor for some of these cancers.
Endometriosis as a precursor lesion.
The sources mention atypical endometriosis, characterized by atypical cells and crowded glands within an endometriotic cyst, as a likely transition point, a precursor lesion leading to these specific endometriosis-related ovarian cancers.
Atypical endometriosis looks like the bridge. A related but distinct condition is adenomyosis.
Adenomyosis, yes. This is where endometrial tissue is found within the muscular wall of the uterus, the myometrium. It's thought to arise from a downgrowth of the basal layer of the endometrium. It's found in up to 20% of uteri.
Endometrium inside the muscle wall.
Microscopically, you see nests of endometrial stroma, sometimes with glands, scattered within the muscle layer. Clinically, it can cause heavy, prolonged periods, myometriorrhagia, painful periods, dysmenorrhea, painful intercourse, and pelvic pain, often worsening just before menstruation. It can coexist with endometriosis elsewhere.
Painful, heavy periods. Endometrial polyps are common. They are finger-like growths or masses that project into the uterine cavity.
Benign growths into the cavity. They vary in size and number and can cause abnormal bleeding or contribute to infertility. The cells in these polyps often have specific chromosomal rearrangements, suggesting they are essentially benign mesenchymal tumors.
Genetic changes suggest they're tumors.
They respond to estrogen, causing them to grow, but show little or no response to progesterone. They are notably associated with the use of tamoxifen, a drug with some estrogen-like effects on the endometrium.
Tamoxifen association.
While usually benign, your sources note that adenocarcinoma can rarely arise within a polyp.
Rare cancer within a polyp. Now, the most common invasive cancer of the female genital tract. Endometrial carcinoma.
Most common GYN cancer now. Due to the success of cervical cancer screening, the ratio has flipped, and endometrial cancer is now more common.
Your sources present a really important framework for understanding endometrial cancer, the type I versus type 2 classification.
Type I versus type 2, fundamental concept. These are two broad categories with different risk factors, precursor lesions, genetic changes, and behaviors. Type I is generally lower grade and less aggressive, while type 2 is higher grade and more aggressive. There are also newer molecular subtypes recognized now that add further nuance.
Type I endometrioid carcinoma is the most common type, 80 to 85%. It's generally low grade and tends to grow more slowly.
The endometrioid type. These cancers closely resemble normal proliferative endometrial glands. They arise in the setting of endometrial hyperplasia and are strongly associated with unopposed estrogen stimulation.
Linked to hyperplasia and estrogen.
The risk factors for type I cancer are essentially the same as for endometrial hyperplasia. Obesity, fat tissue produces estrogen, diabetes, high blood pressure, infertility or never having been pregnant, nulliparity, early first period, late menopause, and certain hormone-producing ovarian tumors.
Classic estrogen excess risk factors.
The genetics of type I are well studied. They frequently have mutations in the PTEN gene, 30 to 80%, which is a tumor suppressor involved in a key signaling pathway.
PTEN mutations are common.
Other common mutations affect the PI3KAK pathway, like PI3CA, KRAS, AIR1A, which stimulates cell growth. MSI, microsatellite instability, is also seen in about 20%, often due to loss of a gene called MLH1, and is associated with Lynch syndrome, a hereditary condition increasing cancer risk.
PI3K pathway, MSI, Lynch syndrome link.
Some have Pele mutations, which cause a very high mutation rate, but are associated with a good prognosis. The precursor lesion for type I is atypical hyperplasia. Microscopically, they form glands that resemble normal or hyperplastic endometrium and are graded based on how much solid growth is present.
POL means good prognosis. Precursor is atypical hyperplasia. Type 2 carcinomas include serous, clear cell, and malignant mixed Mullerian tumors, MMT.
The high-grade types, also called carcinosarcomas. These are significantly more aggressive and have a poorer prognosis than type 1. They tend to occur in older women and are often associated with a thin physique, not necessarily with estrogen excess.
More aggressive, not linked to estrogen.
The precursor for the aggressive serous type is serous endometrial intraepithelial carcinoma.
SEI, the precursor.
Genetically, type 2 cancers are characterized by high frequency of TP53 mutations, over 90%, which is another critical tumor suppressor. These mutations often happen early in the tumor's development and lead to accumulation of the abnormal p53 protein.
PP53 mutations are the hallmark.
They also show high levels of genomic instability and copy number alterations corresponding to a copy number high molecular subtype. TEC2 tumors tend to arise from the surface lining and quickly invade the stroma.
Surface origin, quick invasion.
Crucially, they have a propensity to shed cells that can travel through the fallopian tubes and implant on the lining of the abdomen, peritoneum, spreading like ovarian cancer. This is why they are often already spread beyond the uterus at the time of diagnosis.
Spreads like ovarian cancer.
Morphologically, serous carcinomas have complex papillary or glandular growth with high-grade cellular atypia. Clear cell carcinomas have characteristic clear or pink staining cytoplasm. MMMTs are a mixture of a malignant epithelial component, carcinoma, and a malignant mesenchymal component, sarcoma.
Mixed carcinoma and sarcoma in MMMT. The molecular subtypes mentioned add another layer. Besides PL ultramutated, good prognosis, and MSI hypermutated, good prognosis, associated with immune cell infiltration.
Yeah, the 4 TCGA subtypes.
There's copy number low, typically low-grade endometrioid, good prognosis, and copy number high, includes high-grade serous and high-grade endometrioid, poor prognosis, often with TP53 mutations.
Copy number high is the bad one, usually. These molecular classifications are becoming increasingly important for guiding treatment.
Clinically, endometrial carcinoma is uncommon before age 40 and peaks in postmenopausal women between 55 and 65. There isn't a standard screening test like the Pap smear for cervical cancer.
No good screening test yet. However, abnormal uterine bleeding, especially any bleeding after menopause, is a classic symptom that usually prompts evaluation and leads to early detection via biopsy or curettage.
Postmenopausal bleeding is the key symptom.
Checking for DNA mismatch repair defects is important, as about 20% of type I cancers are linked to Lynch syndrome.
Need to check for Lynch. Outcome is heavily dependent on the stage at diagnosis. Stage I cancers confined to the uterus have a good 5-year survival, 80 to 95%. But stage 4 cancers with distant spread have less than a 20% 5-year survival. Stage rules prognosis here too.
Death is usually from widespread metastases. Treatment for type I endometrioid cancers might involve surgery followed by radiation or chemotherapy if they're spread. More aggressive type 2 cancers often require chemotherapy even if no spread is visibly detected at surgery due to their high potential for microscopic spread.
Treat type 2 more aggressively.
Targeted therapies and immune checkpoint inhibitors are being explored, particularly for certain molecular subtypes like the hypermutated ones.
Your sources also cover stromal tumors of the endometrium, which are less common, making up less than 5% of endometrial cancers.
Much rarer. These include benign stromal nodules and malignant endometrial stromal sarcoma, ESS, which can be low-grade or high-grade.
ESS, low and high grade.
Stromal nodules are benign and look like well-defined nodules. Endometrial stromal sarcomas are malignant and tend to infiltrate the myometrium. Low-grade ESS is often associated with specific chromosomal translocations involving genes like JAZF1 fused to others, which messes with gene regulation. They are considered low-grade malignancies.
Specific fusions in low-grade ESS.
High-grade ESS has different genetic changes and looks more aggressive under the microscope. Both low and high-grade ESS can be tricky because they are prone to late recurrences, even decades after initial treatment.
Late recurrences are a problem. Adenosarcoma is another mixed tumor type containing benign endometrial glands but a malignant mesenchymal stromal component.
Benign glands, malignant stroma, they often grow as large, bulky polyps that can even protrude through the cervix. They are typically low-grade malignancies but can recur locally. A diagnostic challenge can be distinguishing them from large, benign polyps.
Moving to the myometrium, the muscular wall of the uterus, the most common tumor in women, perhaps the most common tumor period, is found here, the leiomyoma.
Fibroids, extremely common.
Commonly known as a uterine fibroid. These are benign tumors of smooth muscle. They can be single or, more often, multiple.
Genetics. While many have normal chromosomes, about 40% show specific, simple abnormalities. Mutations in the MED12 gene are found in a significant majority, around 70%.
MED12 mutations are key.
Your sources are clear. Leiomyomas are not prone to malignant transformation into sarcomas.
Benign stays benign, usually.
Morphologically, they are sharply defined, firm, gray-white masses. They vary greatly in size and can be located in different positions within or on the uterus. Intramural within the wall, submucosal bulging into the cavity, subserosal bulging outwards.
Intramural, submucosal, subserosal.
When cut, they have a characteristic whorled pattern. Microscopically, they are bundles of uniform, smooth muscle cells with very few cell divisions. mitosis. Variants exist with more cells or some unusual nuclei, but the key to distinguishing them from malignancy is the combination of how much atypia is present, the rate of cell division, mitotic index, and whether there's tumor necrosis.
Atypia, mitoses, necrosis, the criteria for malignancy.
The source mentions some rare, unusual variants of leiomyomas that are benign but might behave in surprising ways, like growing into blood vessels, intravenous leiomyomatosis, or seeding on the peritoneal surface, disseminated peritoneal leiomyomatosis.
Benign but weird behavior.
Despite their spread, these are histologically benign. In contrast, leiomyosarcoma is the malignant counterpart. It's an uncommon, highly aggressive cancer that arises de novo from smooth muscle cells in the myometrium or stromal precursors.
Arises de novo, not from fibroids.
Your sources emphasize that they do not typically arise from the malignant transformation of a benign leiomyoma. They often have complex genetic changes and deletions. Interestingly, a subset also have MED12 mutations, which your sources note seems unique to smooth model tumors in the uterus.
Complex genetics, some MED12 overlap.
These are highly malignant tumors. Morphologically, they are usually bulky and infiltrative, or sometimes polypoid into the uterine cavity. The key features that distinguish them from benign leiomyomas are significant nuclear atypia,
Marked atypia.
a high rate of cell division. Mitotic index, the source gives a rule of thumb like 10 mitoses per 10 high power fields, or even 5 with atypia, or if they have an epithelioid appearance.
High mitotic count.
And tumor necrosis. Care is needed with benign leiomyomas that have high mitotic activity, especially in younger or pregnant women. Some tumors fall into a category of uncertain malignant potential.
Sometimes it's hard to tell.
Prognosis for leiomyosarcoma is poor compared to leiomyoma. They are highly prone to local recurrence and spread.
Let's turn our attention to the fallopian tubes. The most common problems here are infections and inflammation, usually as part of PID, ectopic pregnancy, and sometimes endometriosis.
Right, PID and ectopics are big ones for the tubes. Salpingitis, inflammation of the tubes when caused by bacteria like gonococcus, over 60% of cases, or chlamydia, is a key part of pelvic inflammatory disease we discussed earlier.
Tuberculous salpingitis.
Rare in the U.S., but a significant cause of infertility in other parts of the world. Benign tumors are rare. You can find pericubal cysts or larger hydatids of Morgagni near the tubes, which are translucent cysts thought to be remnants from embryonic development. Benign tumors, like adenomatoid tumor, are also uncommon.
Historically, cancer of the fallopian tube was considered quite rare, but your sources introduce a major shift in our understanding.
Yes, this is a crucial modern insight. It's now understood that a significant portion of what were historically classified as serous ovarian cancers actually originate from the epithelium lining the fallopian tube,
Originates in the tube.
particularly the fimbriated end near the ovary. Evidence for this comes from finding serous tubal intraepithelial carcinoma, or ESTIC,
I see.
in women at very high risk, like those with BRCA1 or BRCA2 gene mutations, who have had their tubes and ovaries removed preventatively. ESTIC is a non-invasive precursor lesion found within the tube.
Finding the precursor in the tube was key.
The fact that removing the fallopian tubes at the time of prophylactic ovarian removal significantly reduces the risk of these cancers further supports the tubal origin. We'll circle back to this concept when we discuss ovarian cancer in detail, but recognizing the tube as a primary site for aggressive serous cancer was a game changer.
Huge shift. Now onto the ovaries. These are complex organs that can give rise to a wide variety of lesions due to the mix of tissue types present.
Very complex histology. Common issues include functional cysts and a diverse group of tumors categorized by their origin. The surface epithelial cells, germ cells, and sexacord stromal cells. Primary inflammation of the ovary, oophoreitis, is uncommon, but rare autoimmune forms can cause infertility.
Non-neoplastic and functional cysts are very frequent, especially in reproductive age women. Follicle cysts form when a follicle doesn't rupture properly or reseals after ovulation.
Right, just part of the cycle sometimes. Luteal cysts develop from the corpus luteum. They are part of the normal cycle, but can sometimes rupture or bleed. The source notes that cysts with old hemorrhage and scarring can sometimes be hard to distinguish from endometriotic cysts on imaging.
Can mimic endometriomas. Ovarian tumors are numerous and varied. About 80% are benign, most often occurring in younger women aged 20-45.
Most are benign in younger women. Borderline tumors tend to affect slightly older women, and malignant tumors are most common between 45-65. Despite making up only about 3% of female cancers, ovarian cancer is tragically the fifth leading cause of cancer death in U.S. women.
High mortality rate. Why?
That high mortality rate is largely because it's often diagnosed at an advanced stage. Your sources classify ovarian tumors using the WHO system based on where they come from: surface epithelial stromal, germ cell, and sex cord stromal.
And similar to the endometrium, there's a crucial classification for ovarian carcinoma into type I and type 2.
Yes, type I and type 2 again. Type I are generally low-grade cancers, often associated with precursor lesions like borderline tumors or endometriosis. This group includes low-grade serous, endometrioid, and mucinous carcinomas.
Low grade, often from precursors.
Type 2 are high-grade and aggressive cancers, most commonly high-grade serous carcinoma, thought to arise more rapidly from intraepithelial precursors like estic in the tube, or perhaps inclusion cysts in the ovary.
High grade, maybe from estic or inclusion cysts. Let's start with the surface epithelial stromal tumors, as they are the most common malignant type.
Right, the epithelial ones. Serous tumors are the most frequent, accounting for about 40% of all ovarian cancers and over half of the epithelial types. The term serous refers to the fact that the lining cells resemble those of the fallopian tube.
Look like fallopian tube lining.
About 70% of serous tumors are benign or borderline, while 30% are malignant carcinomas. Benign and borderline types occur in younger women, 20 to 45, while carcinomas are more common in older women, although familial cases linked to inherited mutations appear earlier.
Risk factors for malignant serous tumors
Include things that involve more ovulation cycles or hormonal factors: never having children, nulliparity, family history of ovarian or breast cancer, and inherited mutations like BRCA1 and BRCA2. Low parity, few pregnancies, is also associated with higher risk.
BRCA link is strong here.
Serous carcinoma is divided into low-grade and high-grade. Low-grade serous carcinomas are thought to develop slowly from serous borderline tumors. High-grade serous carcinomas are the more aggressive type and are now believed to arise from either estic in the fallopian tube or from serous inclusion cysts within the ovary.
High grade from estic or inclusion cysts. This brings us back to that fallopian tube origin idea. Finding estic in the tubes of women with BRCA12 mutations who have had preventative surgery was key evidence.
Exactly. And estic has also been found in women with sporadic high-grade serous ovarian cancers, suggesting the tube is a source.
But what about high-grade serous cancers that seem centered in the ovary without obvious tubal involvement?
Good question. Your sources discuss the historical idea that they might arise from cortical inclusion, cysts, little sacs that form when the surface epithelium of the ovary folds inwards. A more recent theory suggests these inclusion cysts might actually form from bits of fallopian tube epithelium that detach after ovulation and implant on the ovary surface.
Implanted tube cells. Interesting theory.
The exact percentage of sporadic high-grade serous cancers arising from the tube versus originating within the ovary is still being studied. But this paradigm shift has significantly influenced how we manage high-risk women, recommending removal of both the fallopian tubes and ovaries, salpingo oophorectomy, rather than just the ovaries.
Remove the tubes too now. Looking at the molecular genetics provides further distinction between serotypes.
Yes, distinct molecular profiles. Low-grade serous tumors, which come from borderline tumors, frequently have mutations in genes like KRAS, BRAF, or ERP2, and usually have a normal, non-mutated TP53 gene.
KRAS-BRAF in low-grade TP53 normal.
High-grade serous carcinomas, in contrast, show very high rates of TP53 mutations, over 90%, often leading to accumulation of the abnormal protein, and these mutations are typically an early event. They generally lack KRAS or BRAF mutations and are characterized by widespread chromosomal instability and copy number alterations.
TP53 mutation is the driver in high grade,
such as amplifications of PIK3CA or deletions of BRCA1 and BRCA2 related ovarian cancers are almost exclusively high-grade serous and almost always have TP53 mutations. Interestingly, BRCA12 mutations are rare in sporadic, non-hereditary, high-grade serous carcinomas.
BRCA cancers are high-grade serous with PP53 mutations. Morphologically, serous tumors are often cystic.
Can be cystic or have surface growth. They can be one large cyst, multiple cysts, or have bumpy papillary growths projecting into the cyst or from the surface. Benign ones have smooth walls or small papillae.
Borderline tumors
show more complex papillae, cell stratification, and mild atypia, but no invasion into the underlying tissue. A micropapillary pattern in a borderline tumor is considered a precursor to low-grade serous carcinoma.
Micropapillary is a worrisome pattern.
High-grade serous carcinoma shows complex, often solid growth with marked nuclear atypia and invasion into the stroma. Estic, the tubal precursor, looks like high-grade serous carcinoma cells, but is confined to the tube lining. Those characteristic small, round calcifications called SAMO bodies are commonly seen in serous tumors.
Samoma bodies are typical. The behavior and prognosis of serous tumors vary greatly by grade and stage.
Hugely variable. High-grade serous cancers have a strong tendency to spread quickly to the peritoneal surfaces throughout the abdomen and pelvis, including neomentum, often producing large amounts of fluid called ascites.
Peritoneal spread and ascites are common.
Primary peritoneal serous carcinoma is also recognized, which is histologically identical but arises from the peritoneal lining itself, presumably from the same coelomic-derived epithelium. Prognosis is directly tied to the extent of spread, stage, and histology, grade.
Grade and stage determine outcome.
Borderline tumors, especially with non-invasive implants on the peritoneum, can spread slowly over years or even decades, although they can eventually cause problems like intestinal obstruction. Low-grade carcinomas also tend to progress relatively slowly.
Borderline and low grade are slower.
High-grade serous carcinomas are unfortunately often widely metastatic at presentation and progress rapidly. Survival rates vary significantly. For tumors confined to the ovary, borderline has a near 100% 5-year survival, while malignant is around 70%.
Confined disease does better.
If there is peritoneal spread, borderline has about 90% 5-year survival, but malignant drops to around 25%. It's worth noting that borderline tumor recurrences can happen many years later, so 5-year survival isn't the full story for these.
Late recurrences can happen with borderline. Mucinous tumors are another type of epithelial tumor. They differ from serous in several ways.
It's a different beast. The surface of the ovary is rarely involved, and only about 5% of primary mucinous ovarian cancers are bilateral. If a mucinous tumor is bilateral, it strongly suggests it's actually a metastasis from another organ, most commonly the GI tract.
Bilateral mucinous usually means metastasis.
These tumors tend to be much larger cystic masses, sometimes weighing many kilograms. They are often multiloculated, divided into many compartments, and filled with sticky gelatinous fluid.
Huge sticky cysts.
Microscopically, they are lined by tall columnar cells with mucin at the top, lacking cilia. The appearance often resembles the lining of the stomach or intestines, less commonly the endocervix.
Looks like GI lining.
Borderline tumors show more complex growth patterns like stratification and tufting, but still lack stromal invasion. Carcinoma is diagnosed by finding clear stromal invasion, often in an expansile pattern. Intraepithelial carcinoma refers to marked atypia confined to the lining without invasion.
Prognosis for stage I mucinous cancers is excellent.
Very good if caught early, with 95% 10-year survival for non-invasive tumors and 90% for invasive stage I. However, spread beyond the ovary is usually associated with a poor prognosis. Again, distinguishing primary ovarian mucinous tumors from metastases is crucial for prognosis and treatment, and bilaterality is a major clue for metastasis.
This relates to the condition called pseudomyxoma peritoni.
PMP. This involves mucinous fluid and implants filling the peritoneal cavity, causing adhesions and eventually intestinal obstruction. While historically thought to originate from mucinous ovarian tumors, recent evidence shows it almost always arises from an extra-ovarian source, most commonly a low-grade mucinous tumor of the appendix that has ruptured and seeded the abdomen.
Usually from the appendix, not the ovary. Endometrioid ovarian tumors make up about 15-20% of ovarian cancers, mostly adenocarcinomas. They show a spectrum from benign to malignant.
Like their uterine counterparts. A key insight into their origin is that 15-20% of them coexist with endometriosis, and these tumors often occur about a decade earlier in women with associated endometriosis, suggesting endometriosis as a precursor for some endometrioid ovarian cancers.
The endometriosis link again.
They also share molecular characteristics with endometrioid carcinoma, such as frequent mutations in the PI3KKT pathway, PTEN, PIK3CA, ARID1A, KRAS, and mismatch repair mutations. TP53 mutations are more common in the poorly differentiated endometrioid ovarian cancers.
Similar genetics to uterine endometrioid.
Microscopically, they form tubular glands that resemble benign or malignant endometrium. They can be solid or cystic. About 40% are bilateral, which often indicates extension from the primary site. These are generally considered low-grade tumors. Prognosis for stage I is reasonably good, around 75% 5-year survival.
Clear cell carcinoma is another type, making up 5–10% of ovarian cancers. These are generally considered more aggressive than endometrioid.
Aggressive type. They are frequently associated with endometriosis, with about 50% coexisting with it, and most clear cell carcinomas are thought to arise from atypical endometriosis. Key driver mutations include ARID1A, about 50%, and KIK3CA, about 40%.
Often from atypical endometriosis, ARID1 AP3CA mutations.
Microscopically, they have cells with clear or pink staining cytoplasm and can form various patterns. Prognosis is aggressive, and even when diagnosed at stage I, they often have a less favorable prognosis compared to other stage I ovarian cancer types.
Poor prognosis even at early stage. Cystadenofibroma is a less common benign epithelial stromal tumor.
Mostly fibrous, it has a prominent fibrous stromal component beneath a columnar epithelial lining. They are usually benign, small, and often multilocular with simple papillary structures. While areas of borderline change or even rare carcinoma can occur within them, metastatic spread from these areas is rare.
Transitional cell tumors, like the Brenner tumor, are also uncommon.
Brenner tumors, yes. The majority are benign. They are typically solid or solid and cystic, usually unilateral. Microscopically, they consist of fibrous stroma with nests of transitional epithelium resembling the lining of the urinary tract,
Like bladder lining.
and often contain central cysts lined by mucinous glands. Sometimes the stromal cells can resemble the Breccia cells, potentially leading to hormonal activity. Malignant Brenner tumors and purely transitional cell carcinomas exist.
The clinical course, detection, and prevention are major challenges for most ovarian epithelial cancers. Symptoms are often vague and nonspecific.
The silent killer reputation. Lower abdominal pain, bloating, changes in bowel or bladder habits, feeling full quickly, pelvic pressure. By the time symptoms are noticeable, the cancer is often advanced.
Late diagnosis is the problem.
Benign tumors are cured by surgical removal. Malignant tumors lead to progressive weakness, weight loss, and cachexia. Spread often occurs when cancer cells break through the capsule and seed onto the peritoneal surfaces throughout the abdomen, leading to ascites. This peritoneal seeding pattern is characteristic.
Seeding the peritoneum.
Spread to regional lymph nodes and distant organs is also possible. Metastasis to the opposite ovary is common, about half at surgery, indicating widespread disease and a poor outlook. The vast majority of ovarian cancers present at a high stage, which is the main reason for the low survival rate compared to cervical or endometrial cancer.
Need better early detection.
There is an urgent need for effective early detection tests, but currently none have sufficient sensitivity and specificity for screening the general population. CA-125 is a blood marker that is often elevated in ovarian cancer, but it's not specific enough for screening and is primarily used for monitoring response to treatment or detecting recurrence in patients with known disease.
CA-125 for monitoring, not screening. So to summarize the key concepts for ovarian epithelial tumors, about 80% are benign and occur mostly in younger women, while malignant tumors are more common in older women.
Right, age matters. The majority of malignant tumors are high-grade serous types, which have a poor prognosis largely due to late detection. There are three main histological types: serous, mucinous, and endometrioid, each having benign, borderline, and malignant categories.
Benign, borderline, malignant spectrum.
Benign tumors are well differentiated with minimal cell division. Borderline tumors show increased proliferation and some atypia but no invasion, and malignant tumors have significant atypia and invasion.
The type I, low-grade versus type 2, high-grade classification is important for understanding their behavior and genetics.
And the evolving understanding of the origin of BRCA-associated and sporadic high-grade serous cancers, likely arising from the fallopian tube epithelium, is a key recent paradigm shift.
Moving on to germ cell tumors of the ovary. These arise from the primitive germ cells and make up 15–20% of all ovarian tumors.
From the egg cells, essentially. Yeah. The vast majority in reproductive age women are benign mature cystic teratomas, commonly known as dermoid cysts. Other types, particularly malignant ones, are more common in younger women and children.
Dermoid cysts are the most common germ cell tumor. Teratomas are fascinating because they differentiate along different germ cell lines, producing tissues from all three embryonic layers.
Can make hair, teeth, brain. Mature, benign cystic teratomas are the most common type, occurring in young women. They are typically cystic and lined by skin-like tissue, complete with hair and sebaceous glands.
Hair and sebum inside. Weird.
These can sometimes be associated with rare neurological conditions called paraneoplastic syndromes, such as limbic encephalitis, which can resolve after the tumor is removed. Microscopically, you can find mature tissues from all germ layers, like skin, brain tissue, cartilage, bone, and other organs.
Monodermal or spiralized teratomas are rare types where only one tissue type is prominently developed,
Like struma ovarii.
made of thyroid tissue.
Exactly, composed mainly of thyroid tissue and can sometimes cause hyperthyroidism. And carcinoid tumors, which are made of intestinal-like tissue and can rarely cause carcinoid syndrome if they're large or spread. It's important to distinguish a primary ovarian carcinoid from a metastasis from the intestine, which is almost always bilateral.
Immature malignant teratomas are rare, aggressive cancers containing embryonal or fetal tissues that haven't fully matured.
Aggressive, immature tissues. Grossly, they are bulky, solid masses with areas of necrosis and hemorrhage. Microscopically, you see immature tissues like immature neuroepithelium, cartilage, bone, and other mesenchymal tissues. They are graded based on the proportion of immature neuroepithelium present.
Grading based on immature neurotissue.
These tumors grow rapidly and have a tendency to spread. Prognosis for stage I low-grade immature teratomas is excellent with surgery. Higher-grade tumors are those that have spread require chemotherapy, which has significantly improved survival rates. Recurrences, if they happen, usually occur within the first 2 years after treatment.
Dysgerminoma is another germ cell tumor, considered the ovarian equivalent of testicular seminoma.
Ovarian seminoma, yeah. They account for about 2% of all ovarian cancers, but are the most common malignant germ cell tumor, making up about 50% of that category. They typically occur in childhood through the third decade of life and can sometimes be found in individuals with gonadal dysgenesis.
Young women associated with gonadal dysgenesis sometimes.
Dysgerminomas are usually not hormone producing, but a small percentage can produce high levels of HCG. They express stem cell markers like OCT3, OCT4, and NANOG, and about a third have KIT gene mutations, all of which can be helpful for diagnosis.
Stem cell markers, KRIT mutations.
All dysgerminomas are considered malignant, but their behavior can vary. About a third are clinically aggressive. They are often unilateral. If confined to one ovary without spread, the prognosis is excellent after surgical removal. They are highly responsive to chemotherapy. Even advanced cases can often be cured,
Very chenosensitive.
with overall survival rates exceeding 80%.
Yolk sac tumors, also called endodermal sinus tumors, are the second most common malignant germ cell tumor.
Yolk sac tumors, yes. They also occur in young women and children. They are thought to arise from the extraembryonic yolk sac lineage and characteristically produce alpha-fetoprotein, AFP, a key tumor marker that can be detected in blood.
AFP is the marker.
Microscopically, they have a very distinctive feature called the Schiller-Duval body, which resembles a primitive glomerulus. You also see hyaline droplets within the cells that stain positive for AFP.
Schiller-Duval bodies are pathognomonic.
Clinically, they present as a rapidly growing abdominal mass, often with pain in a young patient. With chemotherapy, the survival rate is now over 80%.
Ovarian choriocarcinoma is a very aggressive malignant germ cell tumor. It's much more commonly found originating from the placenta,
Gestational chorio is more common.
but it can rarely arise from germ cells in the ovary. Pure ovarian germ cell choriocarcinomas are rare. More often it's found as a component mixed with other germ cell tumors. Histologically, it looks identical to placental choriocarcinoma, composed of syncytiotrophoblast and cytotrophoblast cells.
Looks the same, acts differently. It is rapidly invasive and spreads widely through the bloodstream, hematogenous mets, to organs like the lungs, vagina, brain, liver, bone, and kidney. It produces very high levels of HCG.
High HCG, widespread mets.
Your sources note a critical distinction. Unlike gestational choriocarcinoma, which responds exceptionally well to chemotherapy and is often curable even with widespread metastases, non-gestational ovarian choriocarcinoma arising from germ cells is often unresponsive to chemotherapy and frequently fatal.
Germ cell chorio is chemo-resistant. Poor prognosis.
Rare cases can arise from germ cells outside the gonads, for example, mediastinum. These also lack paternal DNA and are often chemo-resistant.
Finally, sex cord stromal tumors. These tumors arise from the stromal cells that normally support the developing eggs and produce hormones in the ovary.
From the supporting cells. Granulosa cell tumors are one of the most common types in this group. They are named because their cells resemble the granulosa cells of ovarian follicles. There are adult and juvenile types, with the adult type making up 95% and primarily affecting postmenopausal women.
Adult type most common, postmenopausal.
Clinically, they often produce estrogen, which can lead to precocious puberty in young girls, and in adults, it can cause abnormal uterine bleeding and is associated with endometrial hyperplasia and endometrial carcinoma in 10–15% of cases, as well as proliferative breast disease. Occasionally, they can produce androgens.
Estrogen producers usually.
They are considered low-grade malignancies, but have a notable tendency for late recurrences, sometimes 10–20 years after initial treatment.
Late recurrences are characteristic.
Microscopically, they show patterns of cells resembling developing follicles, sometimes with characteristic small, round structures called Call-Exner bodies. Staining for the protein inhibin is a diagnostic marker.
Call-Exner bodies, inhibin positive. Fibromas, thecomas, and fibrothecomas also arise from the ovarian stroma.
The fibrosicle tumors. Fibromas are composed mainly of fibroblast cells, while the comas are made of plump, lipid-rich cells resembling the theca cells, and fibrothecomas are a mixture. Pure fibromas are usually not hormonally active. The comas and fibrothecomas can be estrogenic or, less commonly, androgenic.
Fibromas inactive, the comodes can be active.
Fibromas are usually solid, firm, and gray-white, almost always unilateral, 90%. Microscopically, they are made of well-differentiated fibroblasts. Clinically, they can present as a pelvic mass with pain. They are famously associated with Meg's syndrome.
Meg's syndrome.
Which is the presence of an ovarian fibroma, or fibrothecoma, accompanied by ascites, fluid in the abdomen, and hydrothorax, fluid in the chest cavity. These typically resolve after the tumor is removed.
Fibroma, ascites, hydrothorax.
Fibromas can also be associated with basal cell Nevi syndrome. The vast majority are benign. More cellular fibromas with increased cell division and atypical nuclei are considered fibrosarcomas, which are malignant.
Sertoli-Leydig cell tumors are less common and often produce hormones, most frequently causing masculinization, virilization, or defeminization.
Androgen producers often.
And rarely estrogenic effects. They occur across all ages but peak in the second and third decades. Over half of them have mutations in the dicer1 gene, which is involved in processing microRNAs, suggesting an underlying problem with gene expression regulation. Dicer1 mutations are common here.
Microscopically, they show varying degrees of differentiation, resembling Sertoli cells and Leydig cells found in the testes. They can range from well-differentiated tubules to poorly differentiated sarcomatous patterns. Sometimes they can contain other tissue types, like mucin-producing glands. Less than 5% of these tumors recur or metastasize.
Other rare sex cord stromal tumors include pregnancy luteoma,
benign pregnancy-related, a benign growth that resembles corpus luteum tissue and can cause virilization in pregnant women and their infants, and gonadoblastoma, a tumor composed of a mixture of germ cells and sex cord stromal elements that resembles an immature testis and often occurs in individuals with sex chromosome abnormalities.
Finally, it's important to consider metastatic tumors to the ovary, as they are quite common.
Very common site for METs. The most frequent sources are other Müllerian organs in the pelvis, such as the uterus, fallopian tube, opposite ovary, or pelvic peritoneum. Beyond the pelvis, common primary sites include the breast and the gastrointestinal tract, particularly the colon, stomach, pancreas, and biliary tract.
Breast and GI are common primary sites.
Pseudomyxoma peritoni, as we discussed, is almost always due to spread from an appendiceal mucinous tumor. A classic example of a GI metastasis to the ovary is the Krukenberg tumor.
The Krukenberg tumor,
which is typically bilateral and characterized microscopically by mucin-producing signet ring cells. These are most often metastases from gastric carcinoma.
Signet rings from the stomach. Let's move into our final section, the unique pathology related to gestation and the placenta.
Pregnancy pathology, yes. Your sources emphasize that disorders in this area are crucial causes of complications ranging from fetal death, malformations and poor growth, to serious maternal illness and even death.
High stakes here. First, a brief look at the normal placenta.
Amazing organ. It's an incredible organ that facilitates exchange between the mother and the developing fetus. The core functional unit is the chorionic villus, which contains fetal blood vessels. These villi are surrounded by the intervillous space, which is filled with maternal blood supplied by spiral arteries from the uterus.
Villi is bathed in maternal blood.
Nutrient and gas exchange happens across the layers, separating fetal blood from maternal blood, primarily the fetal capillary endothelium, and the syncytiotrophoblast layer covering the villi. Normally, there's very little mixing of fetal and maternal blood. Fetal DNA can be found circulating in the mother's blood.
Disorders of early pregnancy include spontaneous abortion or miscarriage. Your sources list the most common causes.
Fetal chromosomal anomalies are the single largest factor, accounting for about 50% of early pregnancy losses. Subtle genetic defects can also play a role.
Chromosomal issues are number one.
Maternal factors include endocrine issues like luteal phase defects or poorly controlled diabetes, as well as physical defects of the uterus like large fibroids or malformations.
Maternal endocrine or uterine problems.
Systemic vascular disorders like antiphospholipid syndrome, other clotting disorders, or high blood pressure can also contribute. Infections, though less common in early pregnancy, can also be a cause, including certain protozoa, bacteria, or viruses, particularly ascending infections in the second trimester.
Clotting disorders, infections too. Ectopic pregnancy is another critical disorder of early pregnancy.
Implantation outside the uterus. This is when the fertilized egg implants outside the uterus, most commonly in the fallopian tube. Risk factors include a history of pelvic inflammatory disease, PID, previous abdominal or pelvic surgery, endometriosis, or IUD use.
PID is a major risk factor.
The serious consequence is that as the pregnancy grows, the tube distends and can rupture, leading to severe internal bleeding, hemorrhagic shock, and acute abdominal pain.
Tubal rupture is life-threatening.
Your sources note that despite advances, ectopic pregnancy still accounts for 4–10% of pregnancy-related deaths. Diagnosis involves measuring HCG hormone levels, which will rise but often not as quickly as in a normal pregnancy, using ultrasound to locate the pregnancy, and sometimes biopsy showing uterine lining changes without a pregnancy sac.
Moving to disorders of late pregnancy, twin placentas have interesting variations.
Monochorionic versus dichorionic. Monochorionic placentas occur in identical monozygotic twins who share a single placenta. Dichorionic placentas occur when each twin has its own placenta, which can happen with both identical and fraternal dizygotic twins.
A significant complication unique to monochorionic placentas is twin-to-twin transfusion syndrome, TTTS.
TTTS, yes.
Yeah.
This occurs when there are abnormal vascular connections, anastomoses, between the twins' blood vessels and the shared placenta, creating arteriovenous shunts.
Shared plumbing goes wrong.
This leads to unbalanced blood flow. One twin, the donor, receives too little blood and becomes underperfused, while the other, the recipient, receives too much blood and becomes fluid overloaded. In severe cases, this can lead to the death of one or both twins.
Abnormalities of placental implantation can cause serious complications. Placenta previa.
Low-lying placenta is when the placenta implants low in the uterus, covering or partially covering the cervical opening, OS. This can cause serious bleeding in the third trimester. If the placenta completely covers the OS, complete previa, a C-section is required to prevent life-threatening hemorrhage when the cervix dilates during labor.
Placenta creta is a more severe implantation problem.
Placenta step 2 deep. It occurs when there's a partial or complete absence of the decidua, the specialized layer of uterine lining that normally separates the placenta from the myometrium. Without this layer, the villus tissue of the placenta adheres directly to, or even invades the myometrium.
Invades the muscle wall.
This means the placenta fails to separate normally after birth, leading to severe, potentially life-threatening postpartum bleeding. Predisposing factors include placenta previa, up to 60% of accreta cases occur with previa, and a history of previous C-sections, as the scar tissue can affect decidua formation.
C-section scars increase risk. Placental infections can reach the placenta and fetus via two main pathways.
Ascending or hematogenous. The most common is ascending infection, where pathogens from the lower genital tract travel upwards through the birth canal. This causes inflammation of the fetal membranes, choriomyonitis, and the umbilical cord, pneumocystis. These infections are a major cause of preterm labor.
Choriomyonitis from ascending infection.
Microscopically, you see large numbers of neutrophils, a type of inflammatory cell within the membranes and cord. The second pathway is hematogenous, bloodborne, spread from the mother's circulation to the placenta. This is less common but can be caused by organisms like listeria, certain viruses, syphilis, tuberculosis, or parasites.
Bloodborne infections too.
These tend to cause inflammation within the intervillous space, intervillositis, or the villi themselves, villitis.
Preeclampsia and eclampsia are critical syndromes of late pregnancy unique to humans.
Major pregnancy complication. Preeclampsia is characterized by the onset of high blood pressure, protein in the urine, proteinuria, and often swelling, edema, typically after 20 weeks gestation. Eclampsia is the more severe form, where preeclampsia progresses to include convulsions or coma.
Preeclampsia plus seizures equals eclampsia.
The pathogenesis is complex, but centers around a problem with the placenta that affects the mother's vascular system. A key theory highlighted in your sources involves placental hypoxia.
Placenta not getting enough oxygen.
The placenta doesn't get enough blood flow. This triggers the release of anti-angiogenic factors like SFLT1 and soluble endoglin from the placenta into the mother's circulation. These factors then cause widespread dysfunction of the maternal endothelium, the lining of blood vessels.
Placenta releases factors that damage mom's blood vessels.
Normally, during early pregnancy, trophoblast cells from the placenta extensively remodel the mother's spiral arteries in the uterus, turning them into wide, low-resistance vessels that can deliver abundant blood flow to the placenta.
Normal remodeling is crucial.
In preeclampsia, this trophoblast invasion is shallow and incomplete, meaning the spiral arteries remain narrow and high resistance. This leads to decreased placental perfusion and hypoxia.
Failed remodeling leads to hypoxia.
Your sources state that SFLT1 and soluble endoglin act as mediators, linking this placental problem to the maternal endothelial dysfunction, causing the high blood pressure, protein in the urine, and restricting fetal growth. Coagulation abnormalities are also seen. Mothers with preeclampsia are in a state of hypercoagulability,
Increased clotting.
leading to the formation of tiny blood clots, thrombi, in the small arteries and capillaries of various organs, including the liver, kidneys, brain, and pituitary gland. This is thought to be related to reduced production of a substance that prevents clotting, PGI2, by the dysfunctional endothelium and increased procoagulant factors, partly mediated by SFLT1 interfering with growth factors like VEGF.
Clots cause organ damage.
Animal models where these anti-angiogenic factors are introduced mimic the severe features of preeclampsia, including HELLP syndrome, hemolysis, elevated liver enzymes, low platelets.
HELLP syndrome is related. Microscopically affected organs show damage related to these changes. The liver can show hemorrhage, fibrin thrombi in the small vessels, and areas of necrosis. The kidneys show characteristic swelling of the endothelial cells in the glomeruli, deposits, and sometimes larger thrombi or areas of cortical necrosis. Kidney and liver damage.
The brain can show hemorrhage and thrombosis. The sources also mention distinctive changes in the uterine spiral arteries in preeclampsia, including fibrinoid necrosis and infiltration by macrophages, sometimes called acute atherosis.
Acute atherosis in spiral arteries. Clinically, preeclampsia usually develops after 34 weeks, but it can occur earlier in cases with certain risk factors, like molar pregnancy or pre-existing kidney disease or hypertension.
Usually late pregnancy onset. High blood pressure and edema are often the first signs, followed by proteinuria. Headaches, visual disturbances, or pain in the upper abdomen can indicate severe preeclampsia. Eclampsia is diagnosed when convulsions or coma occur.
Management depends on gestation and severity.
Right. If the pregnancy is at term, delivery is usually indicated. In preterm cases, mild preeclampsia might be managed expectantly, but severe disease or signs of fetal distress usually require delivery regardless of gestational age.
Delivery is the cure.
Antihypertensive medications can help control blood pressure, but do not cure the underlying disease or prevent progression. The high blood pressure and proteinuria typically resolve after delivery. However, there's a long-term risk.
Long-term risks.
About 20% of women with a history of preeclampsia develop chronic hypertension or kidney issues within 7 years, and preeclampsia is associated with a twofold increased risk of long-term cardiovascular and cerebrovascular disease.
Increased future heart and stroke risk. Finally, gestational trophoblastic disease.
GTD. This is a group of disorders characterized by the proliferation of placental tissue, encompassing conditions ranging from hydatiform moles to malignant tumors like choriocarcinoma.
Hydatiform moles are important to recognize because they carry a risk of persistent disease or developing into choriocarcinoma.
Molar pregnancies, yes. Microscopically, they show cystic swelling of the chorionic villi and varying degrees of proliferation of the trophoblast cells that form the outer layers of the villi. They are often diagnosed early in pregnancy, around 9 weeks, by ultrasound due to an abnormal appearance.
Swollen villi on ultrasound.
The risk is higher at the extremes of reproductive age, teenage pregnancies or women in their 40s, 50s. Incidence varies worldwide. There are two main types: complete and partial mole, distinguished by their genetics and histology.
Complete versus partial mole.
A complete mole results from the fertilization of an egg that has lost its own chromosome, so the genetic material is entirely paternal. Androgenesis. In 90% of cases, this happens when a single sperm fertilizes an empty egg and then duplicates its own chromosomes, resulting in a 46XX mole, all paternal.
All that's DNA.
An embryo is either absent or dies very early and is usually not identified. Complete moles carry a higher risk. About 2.5% develop into choriocarcinoma, and 15% develop into a persistent or invasive mole.
Higher cancer risk with complete mole.
Morphologically, a complete mole typically fills the uterine cavity with a friable mass of translucent grape-like vesicles. These are the swollen edematous villi. Microscopically, all or most of the villi are abnormal, showing marked enlargement, a scalloped outline, and central fluid-filled spaces called cisterns. Critically, there is extensive proliferation of the trophoblast cells around the villi.
Grape-like vesicles, diffuse swelling and proliferation. A partial mole results from the fertilization of a normal egg by 2 sperm, usually leading to a triploid chromosome set, 69,000 XXY.
Triploid, usually. In this case, some fetal tissue is usually present, although it may be abnormal. Partial moles carry a much lower risk of persistent disease and a minimal risk of developing into choriocarcinoma.
Lower risk with partial mole, often fetal parts present.
Morphologically, in a partial mole, only a fraction of the villi are enlarged and edematous, and the trophoblast hyperplasia is only focal and less marked compared to a complete mole. Some identifiable fetal parts might be seen.
Focal swelling, less proliferation. Clinically, most moles present as a miscarriage or are detected on ultrasound, showing the abnormal villi pattern.
Usually picked up early now. With the complete mole, HCG hormone levels are typically much higher than expected for the gestational age, and the rate of rise is also higher. Most moles are removed by uterine evacuation, curettage.
Very high HCG with complete mole.
Follow-up involves monitoring HCG levels for 6 months to a year. Persistent elevation of HCG after evacuation suggests the presence of a persistent or invasive mole.
Need HCG follow-up. An invasive mole is when the molar tissue invades deeply into the muscular wall of the uterus, myometrium.
Mole invading the muscle. It's locally destructive and can even send pieces of tissue that embolize to distant sites like the lungs or brain. Histologically, you see villi with those central cisterns and trophoblast proliferation, invading the myometrium and blood vessels. The good news is that invasive moles generally respond well to chemotherapy.
Invasive but chemosensitive. Choriocarcinoma is a malignant tumor of trophoblastic cells.
The frankly malignant one. It can arise after any type of pregnancy, but most commonly follows a molar pregnancy, 50% of cases. It can also occur after a spontaneous or induced abortion, 25%, a normal pregnancy, 22%, or an ectopic pregnancy.
Can follow any pregnancy type.
It is a rapidly invasive cancer that metastasizes widely through the bloodstream. However, it has the remarkable characteristic of responding exceptionally well to chemotherapy.
Aggressive, but highly chemocurable.
It's important to remember that rare non-gestational choriocarcinomas can arise from germ cells in the ovary or mediastinum. These are morphologically identical to gestational choriocarcinoma, but lack paternal DNA and are often unresponsive to chemotherapy, carrying a much poorer prognosis.
Non-gestational type is chemoresistant.
Morphologically, gestational choriocarcinoma is a soft, fleshy mass that tends to undergo extensive necrosis and hemorrhage. Microscopically, it is composed only of proliferating syncytiotrophoblasts and cytotrophoblasts, with no chorionic villi present. There are abundant mitotic figures. The tumor invades the myometrium, penetrates blood vessels, and spreads rapidly.
No villi, just malignant trophoblasts.
Clinically, irregular vaginal bleeding or spotting is a common symptom and can occur during a normal pregnancy, after a miscarriage or delivery, or even months later. The cancer has a high propensity for hematogenous spread, meaning metastases are often present at diagnosis. Common sites are the lungs, 50% of cases, vagina, 30 to 40%, brain, liver, bone, and kidney. HCG levels are typically extremely high.
Very high HCG again.
Although they can be lower if the tumor is largely necrotic or produces less hormone.
Finally, placental site trophoblastic tumors, PSTT, are rare malignant tumors arising from intermediate trophoblast cells at the site of placental implantation.
PSTT, another rare one. Unlike choriocarcinoma, these tumors primarily produce human placental lactogen, HPL, rather than high levels of HCG, so serum HCG levels are typically low.
Below HCG, high HPL.
Microscopically, you see intermediate trophoblast cells infiltrating the myometrium. These cells have eosinophilic cytoplasm, varying degrees of nuclearotypia and mitosis, and they invade blood vessels. They also deposit abundant fibrinoid material. Prognosis is good if the tumor is confined to the uterus, but poor if it invades deeply, involves blood vessels extensively, or spreads. PSTTs are generally less sensitive to chemotherapy compared to choriocarcinoma.
Less chemosensitive than chorio. So reflecting on this deep dive, you can really see how interconnected many of these conditions are. It's not just isolated problems, it's a system.
Absolutely. Whether it's how an infection like HPV can persist for decades and lead to cancer in multiple locations, or how conditions like endometriosis might set the stage for specific types of ovarian cancer, understanding these links really elevates your grasp of the pathology beyond just knowing the names of diseases.
Absolutely. That's the power of digging into the source material like this. You go beyond the surface symptoms and see the underlying cellular changes, the genetic drivers, the developmental origins. Looking at those microscopic details like viral inclusions or specific patterns of cellular atypia, alongside the macroscopic picture of a chocolate cyst or a high datiform mole, it gives you such a richer understanding of the how and why behind the clinical problems the way they are treated.
Gets you to the fundamentals.
It's moving past the checklist to truly seeing the pathology unfold.
Precisely. And while we've covered a vast amount of detail from these sources, this field is constantly evolving with new research shedding light on origins, genetics, and treatment.
Which leaves us with a final provocative thought for you to consider. Given the significant advances in understanding the genetic drivers and potential origins of aggressive gynecologic cancers like high-grade serous ovarian carcinoma, how might future screening strategies evolve beyond current methods to detect these silent diseases earlier, potentially even targeting individuals at average risk?
That's the million-dollar question right now.
It's a complex challenge that the field is grappling with right now.